Okay, I think we're gonna go ahead and get started. Unfortunately, Dr. Sikorsky's having some Zoom difficulties, and he's our co-chair for the Child and Adolescent Psychiatry Grand Round. So welcome everybody. Thank you for joining us. My name is Sam. I work in CAPP as one of the head administrators and managing this lecture series. I'm very glad everyone's able to join us today. It looks like we have a great attendance. So I think I will go ahead and turn it over, or let me quickly introduce our speakers for today. We do have our very own UCSF faculty members with us. Give me 1 second. Chuan-Mei, Petra, do you want to go ahead and just introduce yourselves to everybody? I'm so sorry I don't have your things in front of me because John was supposed to sign on.
You go first, Chuan-Mei.
Hi, everyone. My name is Chuan-Mei Lee. I'm a child and adolescent psychiatrist at Benioff Children's Hospital, Oakland, and I am the Associate Director for Research and Evaluations for the CAPP program that we will be talking to you all about today, and I'm so pleased to be here. Petra.
Thank you. I'm Petra Steinbuchel. I'm a child and adolescent psychiatrist and the director of the Child and Adolescent Psychiatry Portal. And delighted to be here. Thanks. With that, we'll go ahead and jump in. So today we'll be talking about psychiatry consultation to pediatrics and how we can expand access to mental health care. And so looking at this, we're going to talk about potential benefits of integrated care models compared with traditional ones, describe the core features of a successful child psychiatry access program consultation model, and then apply elements of these consultation models in order to both develop effective consultation questions and deliver effective consultant recommendations. Next slide, please. So before launching in, just want to invite you to consider a principle from microeconomics, actually, thinking about, in particular, the graph on the far right, looking at excessive demand, and in particular, the shortage area that's highlighted here between the quantity supplied and the quantity demanded. And that will be one of the principles for our talk. Next slide, please. So these statistics may be familiar to many of us or all of us, but really just want to highlight the very significant and striking prevalence of mental and behavioral health conditions, with suicide being the #2 leading cause of death amongst persons ages 10 to 24, and often with significant early onset of these conditions, 50% by age 14 and 75% by age 24. And often with significant lag times in terms of the onset of symptoms and an actual assessment and treatment. We also know that 50% of all mental health care is provided by primary care providers, and that primary care providers write the majority of antidepressant prescriptions in the United States. We also know that childhood onset of conditions is associated with longer delays in treatment compared with adult onset. Next slide, please. So right now we are having significant challenges, and we don't yet know the full impact of all of these different stressors that are very visible and prominent in 2020 alone. We have not only the coronavirus pandemic and ensuing quarantine and relative increase in social isolation, but also now distance learning. We've had very visible, visual, recent events that have been longstanding reminders of longstanding structural and systemic racism and immigration policy effects, and now more recently wildfires again for the 4th year in a row, having huge fires that significantly impact all of us. Next slide, please. We know from this data from the U.S. National Health Center for Statistics and the U.S. Census Bureau that this is in response to quarantine. There have been weekly surveys for adults assessing generalized anxiety disorder and also depression through GAD-7s and PHQ-9s, and that there's been a substantial increase in the prevalence, with anxiety estimated at 39% in the adult population, depression at 31%, and then combined anxiety and depression at 44%. In contrast, 1 year prior, these prevalences were about 8.2% with symptoms of anxiety, 6.6% with symptoms of depression, and 11% in combined anxiety and depression. We also know that from other previous major disasters, there have been significantly increased rates of PTSD in those who have been quarantined, in particular persons without clear upfront communication. We've also seen increase in alcohol sales across the country and presumed increase in substance use concerns. There have also been significantly increased rates of sleep difficulty, irritability, and inattention in a study published in Pediatrics that was done just after quarantine in Shanxi, China. Next slide, please. We also want to acknowledge that the storm may be the same for all of us, but that it looks and feels very different, that we have different boats that we all are in. And depending on your resources, you may have more access to care than others. This includes recent reports in the news of persons with means being able to hire their own personal firefighter operations. And we know that that's true, that there are variable levels of access to mental health care, often with very siloed systems between the Medi-Cal, Medicaid insured system, Medicare, private insurance, and those who have the ability to pay cash. Next slide, please. In contrast to the significant demand and prevalence, we have significant workforce shortages. So this map highlights the child and adolescent psychiatrist workforce shortage. Currently, there are about 8,000 practicing child and adolescent psychiatrists in the United States, and there's an estimated need for over 40,000 currently. Similarly, we have about 105 practicing psychologists in the United States, with significant increase in estimated demand above and beyond that. And we have about 800 practicing developmental pediatricians. Next slide, please. We also know that there have been some longstanding challenges in terms of how mental and behavioral health care is delivered. So physical and behavioral health care has often been delivered separately. You can say thank you. And this is in part an artifact of longstanding stigma and separation of mind and body concerns. We also have had very separate record-keeping systems that have inconsistent information sharing. There have been separate financial structures in place through insurers that often mental health care is carved out. And also navigating the system is incredibly challenging. So the image on the bottom of trying to navigate from physical medical health care and then putting the pieces together yourself and creating your own bridge to get to a more traditional model of care that's symbolized here with the picture of Freud. Next slide, please. Acknowledging these concerns, we know that mental and physical health care problems are significantly interwoven, but that the care for these conditions is often fragmented. And in order to mitigate this, the idea of more integrated care has emerged. We know that primary care settings in particular can be really ideal places to serve mental health needs because there's greater access, there's reduced stigma, and it can be cost effective to do this. However, we're still burdened in some ways by separate mental health addictions and physical healthcare systems that can be difficult to navigate, as well as different treatment systems lagging behind one another and often remaining siloed. Next slide. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, has come up with these kind of stages of integration with coordinated care, having a heavy emphasis on communication. This can include routine screening, having referral relationships, having routine information exchange to help bridge cultural differences, and sharing of brief algorithms and community resources. Co-located care is often focused on having physical proximity to different provider types that work together, ideally in teams, where there's increased information sharing and the ability to consult in order to increase skills and increase the level and quality of services that's delivered. Integrated practices really focus and emphasize practice change. This includes shared treatment planning, being able to work in care teams, and have a use of a database for population health tracking. Next slide. So what is meant by integrated care? This is intended to emphasize more of a whole person care approach that helps to create partnerships across all aspects of healthcare, and is facilitated by a variety of clinical and structural and financial arrangements and community supports that help to remove barriers between physical and behavioral health care. We have a few different examples here. So one is the patient-centered medical home, which helps to coordinate aspects of preventative care and acute and chronic care needs. These are usually based in teams with a whole person approach, trying to integrate mental and behavioral and physical primary care. They usually provide comprehensive care management, coordination, and follow-up. And they also offer patient and family support and referrals to community and support resources, and with the intention of health promotion. Collaborative care is a model that's been developed through the University of Washington that introduces some newer services, namely having an on-site behavioral health care manager. This can be a psychologist or social worker or nurse or nurse practitioner, and then a consultation with a specialist. And we'll talk a little bit more about that in just a moment. And then we also have hub-based systems. So these provide immediate consultation, plus case management and as needed specialist evaluation. And child psychiatry access programs fall into this third category of the hub-based systems. Next. So this table represents a more child psychiatry focused representation of the slide that we just looked at. And looking at the first column here, behavioral health clinician model, this is where there's an on-site behavioral health clinician that could be a social worker, psychologist, or nurse practitioner. These tend to have a broad reach in terms of impact on the practice, but it does really require very intentional and strong teamwork. And this does exist currently, for example, at BCHO within primary care, and also at the school-based sites and teen clinic. The Child Psychiatry Access Program is what our Child and Adolescent Psychiatry Portal is, and we'll talk more about that in just a little bit. And then collaborative care will be on the next slide. Go there. So actually we'll talk about collaborative care in just a moment, but these are kind of the core principles of effective integrated care. So looking at having team-based collaboration, having a patient-centered approach being at the very heart of this. Looking at measurement-based care, this means being able to use rating scales and be able to track patient outcomes through the use of a centralized database like a registry. And this helps to promote accountable care that is effective and involves treatment to target. Next slide, please. So this diagram illustrates the core features of the collaborative care model that's been developed through the University of Washington Ames Center. And this really puts the patient at the very center of the process. The primary care provider is an integral person in this, and as is the psychosocial team, which can include just one of these providers or maybe a team of them, including a therapist or psychologist, social worker, as well as patient navigator. And then outcomes are tracked in the caseload registry. And then the psychiatrist consultant, who has the dotted line kind of approach with the primary care provider and with the patient, but who regularly reviews the caseload registry and regularly reviews outcomes, and then can consult with both the psychosocial team and the primary care provider, and then with the patient as needed. Next slide, please. The idea with these kinds of approaches is that it allows patients with lower severity mental health conditions to be seen in primary care and or with a behavioral health provider as needed, and that there's a stepped care approach that only more intensive services, including psychiatric consultation or longer term treatment, are reserved for those with more severe mental health conditions. Next slide, please. So thinking about a stepped care approach, this is another way of taking a look at, what is the overall population health need, and that many people fall into these lower step 1 and step 2 categories where there's really no disorder or only mild symptoms, and what level of care is appropriate. This could be including psychoeducation, brief interventions that are performed in primary care, time-limited treatment, and then the more severe presentations receive more complex and more specialty care at the top of the pyramid. In terms of overall prevalence of different conditions, we know that, that looking at depression in teens right now, the estimated prevalence is between 10 and 18%. So not everyone is going to fall into the more significant severity category. Anxiety also has different levels of severity and can be seen sometimes just in primary care. Next slide, please. This is a study in pediatrics that looked at data from medical expenditure panel survey between 2008 and 2011, looking at patients ages 2 to 21 with outpatient visits for mental health problems in the past year, who saw primary care providers, psychiatrists, and psychologists, social workers for these types of conditions. And of these, we know that about 35% received outpatient care and only saw a primary care provider. 26% of these saw psychiatrists only, and then 15% saw psychologists or social workers only. About a quarter of these patients saw multiple providers, and the majority of the visits that were handled more in primary care were more ADHD focused. Next slide, please. And parts of this that I just wanted to highlight are the level of complexity that is seen in primary care. So if you can advance the slide, it'll help to highlight this on table 3. That here, so for any mental health condition, the primary care providers saw a majority of ADHD and single conditions like anxiety or depression a little bit less frequently. And then combined therapy was reserved for more of the complex coexisting conditions. Next slide. So given that primary care providers receive about 1 month of training in developmental pediatrics, generally speaking, during their 3-year pediatric residency, and that they may self-select to do psychiatry electives or to rotate, with more integrated care approaches, but they often have very limited training in managing mental and behavioral health conditions. And so they have varying degrees of comfort in doing so. And so this slide was developed by a colleague, Madeline Lansky, who practices collaborative care within the Alameda County behavioral health system and has likened this to the stages of grief. And we like to share this when we're doing enrollment meetings because it helps to soften things a little bit. Often pediatricians are varying degrees of frustrated with not being able to access care more readily. And it helps to highlight the benefits of the process with leaning into it a little bit more. And with that, I'm going to turn it over to Chuan-Mei.
Next slide, please. So we're going to talk to you a little bit more about child and adolescent psychiatry access programs. And so like Petra talked about before, there's a real case that pediatricians can be so helpful in managing childhood mental health issues in primary care, but they may need a little bit more support. The child psychiatry access programs are a remote consultative model whereby pediatric PCPs receive consultation on any mental health concerns of their patients. And the thing that we want to emphasize here is that this model is in an educational role, and the consultants, we are not assuming care for the patient directly. One of the first programs was in Massachusetts, and Barry Sarvet, who was the statewide director for that program, mentioned a three-pronged model for remote consultation. And so those are telephonic consultation, training and education, and care coordination and referrals. And he felt like these were a three-legged stool that all prongs of this model needed to be part of the program to have a successful access program. Next slide, please. This is a map of the US showing all of the different types of child access programs available in each state. These programs have become quite widespread and very popular. The first statewide implementation, like I mentioned, was in Massachusetts. It was called MCPAP, started in 2004 by John Strauss and Barry Sarvet. And since then it's spread quite widely throughout all the states. Now it's been replicated in 30 plus states, and 21 of which receive statewide funding. The second implementation that I do want to highlight is PAL, the Partnership Access Line in Washington State, and our division head, Dr. King, was quite familiar and quite involved with that implementation. Next slide, please. So MCPAP studied their program and found a number of features that they thought were necessary for a successful implementation. They found that they needed to have universal access for independent of payers or provider network, so that anyone who called could get a timely response. That response had to be quick and timely, had to be high quality, had to be people had to have some access to psychiatric assessments, referrals, and resources. People who were answering the line had to have knowledge of local resources, and there had to be relationships developed between the program and the primary care providers that they served. So just to talk a little bit more about MCPAP, they now tap into some private insurer contribution. Over 80 insurance companies contribute, in addition to statewide funds. The cost per child for the MCPAP program is about $2 per child, and they have over 95% of pediatric practices in Massachusetts enrolled. In the course of studying their program, they found that 75% of enrolled practices and 41% of providers in the state of Massachusetts have used MCPAP at least once. This is from a 2014 survey that they performed. Of these practices, 21% of the respondents indicate that that they have access to co-located or integrated child psychiatrists, and 44% have access to behavioral health therapists. So not a lot of access to the other types of integrated practices that Petra spoke about earlier. Next slide. The second implementation that we had described is the PAL line in Washington State. And likewise, that they performed an evaluation of their program impact. And I just want to highlight here that they found that there was really high satisfaction among the PCPs, and that the children that the PCPs called about really did have multiple and serious mental health problems. They didn't just call, well, a lot of the calls were about medication, but they didn't, the consultants didn't end up just talking about medication. They also really encouraged the appropriate use of psychosocial treatments. Next slide, please. So I want to talk a little bit about our program here at UCSF. We have a child and adolescent access line called the Child and Adolescent Psychiatry Portal, CAPP for short. And this was a program that Dr. King really spearheaded and led. We first performed a number of site visits. We did go to both MCPAP and PAL in the spring of 2019. And we met with a lot of stakeholders who might be at this meeting now to talk about what were the needs and what were the resources that we could provide. And so as a result of this information gathering from our stakeholder meetings and our site visits, we were able to then take that and go to a partner clinic, which we then asked them what were some of their needs. We used an iterative design thinking approach to combine all of these insights. And then we were finally able to launch our program at our partner Pediatrics site, which is part of the UCSF UBCP network, in September 2019. So it's been almost a year since we first launched, which I'm really proud to say. Next slide, please. So our program CAPP, our mission is to meet the needs of pediatric primary care practices serving as frontline care providers for mental health and to improve access to behavioral health treatment in many of our communities. Our services, like the three-legged stool that Dr. Sarvet described, are remote psychiatric consultation, which we do by telephone, continuing education, which we provide CME events and webinars, and resources and referrals. Next slide, please. So, I'm sorry, next slide. There we go. So we wanted to highlight how our organization worked, and the best way that we thought of was using a logic model. And so we wanted to highlight what were the problems that we were encountering, what were the problems that we heard from our partner pediatricians. Many of them stated that they felt uncomfortable managing mental health concerns given the limited training that they had in residency. And also that they had limited mental health resources to offer to patients. And so these problems map onto the solutions that we developed, which were the remote psychiatric consultation, where we are able to have the PCP call in and ask any questions that come up about specific cases or more general questions. Then we deliver the CME programming, and then we're adding on a new resource and referral type of service. And then with these, we want to track our impact, which is the outcomes. We want to measure short-term utilization and satisfaction with the services that we provide. We want to improve PCP self-reported knowledge, skill, and comfort in managing mental health concerns. And then longer term wise, we want to increase access to mental health care for pediatric primary care patients. Next slide, please. So here's just a look at, in the year that we've been operating, what practices that we've enrolled. As you can see, we're enrolling practices throughout Northern California. We have 38 practices enrolled so far as of last week in 7 counties: Alameda, Contra Costa, Marin, San Francisco, Santa Clara, and Sonoma. We've had a total of over 170 calls. As part of this enrollment, we've been looking into how are primary care providers perceiving managing mental health concerns and referrals, barriers and facilitators to accessing mental health, and then ways our telephone consult liner and our continuing education program might help. So we've been actually conducting focus groups with some of our enrolled partner clinics right at the time of their baseline enrollment to look at some of these issues. And we've been able to get IRB approval so that this can be part of a formal study, a qualitative study to look at themes that are coming up. And, unsurprisingly, we've found that a lot of people don't have the resources that they need. They don't know where to turn to, and are really having a lot of trouble helping their patients with mental health concerns. With COVID, it's been even harder. And I think COVID has highlighted some of the divide between patients who have resources and patients who do not. And it's been what we've noticed in our preliminary findings is just that how stark that socioeconomic divide is, and between people who can access mental health resources and people who cannot. Next slide, please. So just a little bit more data. We've been collecting data on demographics of the patients who are being consulted on, the time of day and day of the week that the call happens, and also the consult category. You might notice that medication is the number one question that people ask, that PCPs ask us about. And that's not surprising because that is sort of what's in the PCP toolbox. Next slide, please. So what to expect during a consultation? We really want to provide practical and useful advice that the PCP can implement that day. We want our consults to be timely, tailored, and culturally attuned. We want it to be a teachable moment and a learning exchange, so that it's not just something that is a one-time use, but is something that they can apply to future patients that they might see. And it goes in both directions. We use a 5S's communication tool that was initially developed by folks at the University of Maryland. And it has 5 dimensions that we ask the primary care provider about during this brief telephone conversation. We use this and we teach this to our primary care partners to maximize communication and facilitate problem solving. So the 5 dimensions are safety, specific behaviors, setting, scary things, and screening and services. And we'll go into this a little bit more. So of course we care first and foremost about safety. We might ask if the primary care provider has any concerns about the patient's safety. Are they safe? Are the parents safe? We'll then go and ask about specific behaviors. What are the behaviors that they're seeing in the home or what they're reporting from school? Next slide. What setting that these behaviors are happening in. And you all know that some behaviors could just happen at schools, some could just happen at home. Next slide. And then scary things. A lot of children, unfortunately, have experienced or witnessed trauma. And so one question that we found that is, good language that we can teach our primary care providers to ask is, has anything hard or scary happened to the patient or family? And that's a way to ask about trauma that is understandable by most folks. And then finally, screening or services. Has this child had previous therapy, previous med evaluations? Has this child had any screening tools completed, like the PHQ-9, the Vanderbilt, etc.? What's been tried before? Now I'd like to turn back to Dr. Steinbuchel for the rest of the talk.
Thank you, Chuan-Mei. So I just wanted to share some consultation questions and examples, and really wanted to underscore how complex the patients that are seen in primary care really are, and how much primary care providers are currently already managing, and often with not very much time. And so these are some recent examples. One is a 14-year-old with Pierre-Robin influence, also with intellectual disability and worsening behavioral problems since quarantine. And the stated consultation question was help with medication recommendations to help with this. And as with other consultation settings, helping to shape the consultation question to expand beyond just the medication recommendations. There was also talk about how to help access regional center services in general, and then what types of behavioral interventions could be useful, what types of school-based resources could be useful, and how to navigate those systems. With the second patient, this 12-year-old, so the stated question was helping with resources in this 12-year-old with a history of pretty significant sexual abuse, as well as eating disorder symptoms and family conflict, and then new behaviors in the context of being home during quarantine. And so there was a little bit of discussion around, would a medication be helpful in this instance, and talking through the pros and cons of that, and or benefits. And then also, embedded in this was a consideration of CPS reporting and discussion around that. With this 7-year-old with ADHD and comorbid anxiety, and then again with worsening aggression in the context of remote learning, the family had stated that they had tried medication previously and didn't like them, didn't like the side effects. And so part of the discussion here was really helping with language pearls and how to provide that psychoeducation in a way that would help to mobilize the family to be willing to reconsider medication. With the 17-year-old with TBI, the mother wanted help in navigating kind of the conservatorship system. And again, some of the consultation here was helping to provide some coaching on helping the mother with her guilt around this, and her own needs, and what was going to be most effective for the patient, and then also what was the primary care provider's role in this, and how to enlist other resources and supports. And then last, with this 3.5-year-old with new onset trichotillomania, this was a patient that we were referring to our psychologist for our second step psychologist consultation component of our program, which I'm going to describe a little bit more. But this is new behavior in the context of the birth of a new sibling and wanting help with that. Next slide. So wanting to think about what are effective components of our recommendations and what can our program help with. So our program really helps with diagnostic challenges and utilizing elements of social learning theory. We learn better in the context of current concerns and through relationship, learning from peers. And so with this peer-to-peer consultation, this can assist with clarifying diagnostic challenges and helping to promote recognition and developing illness scripts for presentations and diagnoses that a pediatrician may initially feel less comfortable with. We also are seeing people who are consulting repeatedly, and so their initial consultation question may be more basic, and then the second consultation, they've learned how to interpret some of the rating scales that we're suggesting above and beyond the PHQ-9. And then the third consultation might be more sophisticated around how to consider stopping a medication and when best to do that and how to do it and how to talk with the family about it. In terms of what, so being aware of more assessment tools, rating scales, and other measurement tools that we use, and getting more comfortable with those. With treatment planning, again, through more iterative use, this really helps to increase confidence and competence over time. And then one of the biggest questions is really around, helping with language and being able to provide language pearls that are anxiety relieving, not only for the provider, but also for the patients and families. Next slide, please. So some promoters for child psychiatry access programs and for our programs is really being able to offer timely advice. Back to what Dr. Lee was describing, we do have a direct connect, so being able to connect the provider who is maybe in the middle of a patient appointment, or who is calling right after a patient appointment, or sometimes also just in advance of a patient appointment later that day, that they're wanting to get some coaching on how to think about their interventions and what to be looking for, making sure that we're able to be responsive and also culturally attuned and sensitive to what's happening, wanting to make sure that we're pushing the provider kind of just to, and then maybe just a little bit beyond their comfort zone, but not too much more than that. So thinking about how much time they might have, how much anxiety they might be feeling in the moment, and making sure that we're basing our recommendations on what that provider needs. We also know that through building more relationships, being able to have kind of iterative consultations over time, and also through our continuing medical education programming, that we're building those relationships, we're cultivating trust so that they feel confident in the recommendations that are being offered. We know that some barriers to these programs can be, a worry. You're going to ask me to go beyond my comfort zone. I don't want to, manage behavioral health conditions. This is really, I want to be able to refer this out in a more traditional consultation model. Also, practices may have their own embedded behavioral health consultants or have access to other providers that they consult with routinely. And so then they would be less likely to utilize a program like this. Time constraints are a frequent concern expressed by providers, and helping to think about other ways of billing, both consideration of whether it's appropriate to use time-based billing or elements-based billing, and thinking about complexity, being able to flexibly kind of see patients back more frequently than they might otherwise if they were just addressing a physical healthcare need, and making sure that they have embedded time in their schedule to actually consult during the time that the consult line is available, which is currently during regular business hours. Next slide. I'm wanting to also highlight that we do offer more than just the real-time direct connect consultation, but also regular educational programming that's aimed at not just imparting the didactic information, but also is helping to build community and helping people to come together and to cultivate that relationship and that trust. We also recently just added a second step psychologist consultation, which is intended to be a one-time brief consultation for either the parent or the family member or the primary care provider to consult directly with a psychologist around specific concerns. Next slide. So we're really delighted that currently Sally Cantrell, who is a psychologist who specializes in early childhood mental health and who's been based out of Children's Oakland, and also Lauren Hack, who is a psychologist in the ADHD clinic and also in San Francisco General, and who's currently heading the school-based consultation program for the Child Psychiatry Training Program. They are offering discrete consultation office hours during the week and focused on the 0 to 6 age range, and then also the 7 to 21-year-old age range, being able to offer this type of guidance that could be, behavioral management recommendations, and or thinking about how to triage and navigate some of the resources that are out there in the complex system that exists. Next slide. We have hosted a number of educational events. Our kickoff training was October 26th of last year, and we had kind of commonly seen conditions in primary care, including anxiety, depression, ADHD, and suicide assessment. And then this summer, we hosted a mental and behavioral health and pediatric primary care in COVID-19 webinar series. And we are really excited to share that we're going to be hosting an ACEs and trauma-informed pediatric care in COVID-19 on October 10th. And next slide, please. In terms of next steps, we will be having a strategic planning meeting at the end of September and reviewing more qualitative feedback that we've received, as well as data and brainstorming about further innovations. We know that we want to look at practice shifts that have occurred already in the context of COVID, and looking at kind of increasing virtual care delivery, as well as addressing some of the billing challenges more directly. We also want to look at launching a Project Echo Style Learning Collaborative and looking at collaboration with specialty care. We have been in the process of expanding throughout Northern California, as Chuan-Mei was describing, and looking to continue to build and grow through partnerships. And then we are looking, as we hire more folks, to also offer direct consultation for more complicated presentations that seem difficult to manage in primary care alone. And with that, next slide, please. Really excited to share about our growing team. And we have a couple of new folks starting, including Milena Kaufman and Zara Zeptel, who are starting, I think, very shortly. So with that, we'll pause here and ask if there are any questions.
Can I sneak in a quick question?
Yeah.
Great. First, I just want to join Santoy Trotter in congratulating you on your first year of operations. It's really an extraordinary trajectory that you've established. Really exciting to see the growth of the program and its utilization. Just wonderful work. My question goes back to what Chuan-Mei put up in terms of longer term outcomes. And I'm wondering if you could share specifically the kinds of outcomes that we might be able to capture with the service in terms of the longer term clinical progress.
And you cut out for a moment. Chuan-Mei, do you want to?
Yeah,
Could you hear
sure.
the question, Chuan-Mei?
Yeah, so, you know, I think we want to capture whether or not our service is increasing access to mental health care for children in pediatric primary care. I think the access issue is a little bit easier to study rather than direct mental health outcomes. So, you know, of the many programs out there in the US, no one has looked at direct mental health outcomes. And there's a reason, which is that it's just so difficult to do because this is a provider-facing program. Designing a way to look at patient-level outcomes is just very difficult. Certainly that it's possible, but it's just a very difficult study design. So instead, I think what we should look at and we want to look at is if we're improving patient access. So it's a little bit of a proxy.
Great, thanks.
There was a moment, I don't know if it was just an IT glitch on my end, but I don't know if you mentioned, Chuan-Mei, that there have been some exploration around patient perceptions of the program, and through MCPAP that they've studied this, and that patients actually have reported, you know, seeing the improvement in their primary care provider's care over the course of utilizing the service, and feel more that they can improve and their experience of it is better.
Okay. Are there any other questions for Petra and Chuan-Mei? We do have about 5 minutes. Just a little reminder to, if anyone wants more information about their event on October 10th, feel free to reach out and I'll be happy to connect. But in the meantime, does anyone else have any questions regarding their presentation or about their programming? Again, to extend that congrats on your guys' year 1. No other questions?
Can I sneak in another congrats?
Go for it.
I just want also to thank you for getting us off to such a great start in the Grand Round schedule for the coming year. We had an extraordinary turnout. I think we were up to 62 at one point, and people from across all of our sites. So thank you for setting the bar so high as we start the new Grand Round season. One other thing, I think, Sam, do you want to just also remind people about the need to re-register for Grand Rounds from week to week?
I just put it in the chat function as you were speaking. So because of, Zoom security and everything, we are going to have to make Zoom links for each series going forward. So you do have to pre-register for each event to get access to the Zoom link and meeting ID. They are different each lecture series. And if you have any questions about the process for CME or CAMFT credits, feel free to email me. I'll put my email down below. Next week, we will be here at the same time, different Zoom links. So just make sure to register your email and you'll get all the details. Next week, we do have Dr. Michelle Roseman from the University of Denver who will be speaking. Go ahead and feel free to pre-register on this Department of Psychiatry and Behavioral Health Science website. You could go to the education portion and you'll see child and adolescent psychiatry grand rounds listed. Again, any questions? I know it's a little different process than usual, but I appreciate everybody for coming and participating. And if you have any questions about this presentation, again, feel free to reach out for that ACEs and trauma-informed event that they have on October 10th. And any other questions, feel free to reach out. And I look forward to seeing everybody next week.
Thank you. I was just able to get through all of my hoops and loops to get into this program. I'm sorry I couldn't introduce Petra and Chuan-Mei, but I have been doing the grand rounds since Dr. Irving Phillips had appointed me in that position, and this is the year that I'll be phasing down and out from my chairing these grand rounds. Has been a real lifetime experience for me, and I can't thank the new committee with the enthusiasm and imagination that they bring to it. So I'm very happy to be phasing down and giving all my help and congratulations to our new committee. So see you next week. Thank you.
Thank you, everybody. Thank you, John.